Welcome to the SAEM21 Thursday Keynote Address and Plenary Session. I am Dr. Susan Promise, Editor-in-Chief of Academic Emergency Medicine Education and Training. In a short while, Dr. Darren Beam will be joining me to moderate the plenary abstracts. But first, we're very fortunate to have Dr. Eric Holmboe here with us today as our keynote speaker to discuss achieving desired outcomes in graduate medical education. Dr. Holmboe is Chief Research, Milestones Development and Evaluation Officer at the Accreditation Council for Graduate Medical Education, ACGME. He is Adjunct Professor of Medicine at the Yale University School of Medicine, the Uniformed Services University of the Health Sciences, and the Feinberg School of Medicine at Northwestern University. He previously served as the Associate Program Director, Yale Primary Care Internal Medicine Residency Program, Director of Student Clinical Assessment, Yale School of Medicine, and Assistant Director of the Yale Robert Wood Johnson Clinical Scholars Program. Before joining Yale in 2000, he served as Division Chief of General Internal Medicine at the Naval Medical Center. Dr. Holmboe retired from the U.S. Naval Reserves in 2005. His research interests include interventions to improve quality of care and methods in the assessment of clinical competence. His professional memberships include the American College of Physicians, where he is a master of the college, Society of General Internal Medicine, and Association of Medical Education in Europe. He is an honorary fellow of the Royal College of Physicians in London, honorary fellow of the Royal College of Physicians and Surgeons in Canada, and honorary fellow of the Academy of Medical Educators. Dr. Holmboe is a graduate of Franklin and Marshall College and the University of Rochester School of Medicine. He completed his residency and chief residency at Yale New Haven Hospital and was a Robert Wood Johnson Clinical Scholar at Yale University. Welcome, Dr. Holmboe, and thank you for being here today.
Well, thank you so much for having me, and thank you for the kind introduction. I am going to go ahead and share my screen and get started. It's an honor to be with you. As you heard, I retired from the Navy in 2005, but during my career, I spent 4 years as a general medical officer. And during that time, actually worked extensively in an emergency department. So very grateful for what you do. And it's, I said, an honor to be with you. These are just my disclosures, which are also available to you. First and foremost, I want to thank all of you for what you've been doing. We're well aware at the ACGME it's been a very rough 15 months. And you, being in emergency medicine, have been on the front lines. And we're very grateful for your service and your continuing dedication to education during these very difficult and disrupted times. This is one of my favorite murals from the past year, but it's also a very sobering one. This was created by an artist of all the healthcare providers who lost their lives in the early stages of the pandemic back in 2020. So again, I just want to acknowledge the sacrifice and the dedication you've all shown this past year. For my talk, I'm going to cover the following objectives. I'm going to discuss the early lessons learned from the implementation of the 6 general competencies and milestones. We'll briefly discuss and apply the key developmental learning theories and approaches in residency training. Third, we'll examine early data from learning analytics with milestone data to support learner professional development. And finally, we'll discuss next steps in the outcomes-based education journey for graduate medical education and specifically emergency medicine. So let's start with a brief review of outcomes-based medical education. This is actually not a new concept. It's been around for a number of decades. And I think this is a nice article written by one of the leaders of the movement, Ron Harden, in Dundee, Scotland, that really defines what outcomes-based education is. The central tenet is that you start with the end in mind, and you focus on what type of physician will be produced. And the structure and process of training programs should flow from these outcomes. In an outcomes-based model, the educational outcomes should be clearly and unambiguously specified. And these educational outcomes then determine the curriculum content, organization, and timetable, the teaching methods and strategies, the assessment processes, and finally, it should help shape the learning environment. In 2010, Julio Frank and colleagues, working with an international group of educators and policymakers, reflected on the past 100 years in this Lancet Commission report. And they pointed out, in the 20th century, there was a heavy focus on curriculum. This was important. If you think back to the Flexner Report in 1910, there's very little structure, guidance, and standards for a curriculum. And that curriculum during the last century drove educational objectives, and they may or may not be associated with some type of assessment. We also know in the 20th century, assessment was predominantly focused on medical knowledge, not a bad thing, and our ability to measure knowledge through standardized tests actually improved during that time. Toward the end of the latter part of the century, we began to be able to use simulation, such as standardized patients, things like ACLS. But what they pointed out is that we've probably had it backwards. They argued that what we really need to do is start with the health and healthcare needs of the patients and populations we serve. In other words, that's what the outcome or the end in mind should be. And from these health and healthcare needs, we define competencies that should connect to meaningful clinical outcomes. And then and only then do we really develop and design the curriculum and assessment programs to move the programs forward. Now, one thing about this slide that I find a little bit limiting is it makes it appear as if curriculum and assessment are separate activities. They're not. They're highly interdependent. Now, when we think about outcomes, what are the outcomes of interest? Well, in our current framework, it's the quadruple aim, which means we strive for better outcomes or experiences of patient care that should be safe, effective, efficient, timely, equitable, and effective. We need to do that at lower cost. We need to make sure that we're attending to population health outcomes. And then the fourth thing that we've added is to improve the clinician experience, because we now have much better data that shows that when you're overly fatigued or you're burnt out, that clinical care can suffer. So this is our North Star. So how do we get there? How does medical education connect to that? That's where an outcomes-based approach occurs. And so our curriculum should now be guided by competencies, which just simply refer to the abilities of the individuals, that is then linked to ongoing meaningful assessment. You've all heard the adage that assessment drives learning, but it also encourages you to think about how learning should drive the right kind of assessment. This is an ongoing iterative loop. All of this, as I said, has to occur in a high-functioning clinical learning environment. That's what the CLE stands for in this particular schematic. We now have evidence that shows that if our trainees learn in poorly functioning institutions, the outcomes tend not to be as good for them. So let's take a look at our journey in the United States. Believe it or not, the work on the 6 general competencies we currently use began in 1997. And in February of 1999, the 6 general competency framework was approved by the ACGME and the American Board of Medical Specialties. And then the formal launch of the Outcome Project began in July of 2001. So we're now about to reach the 20th anniversary of the beginning of this journey. This was what the original Outcome Project looked like when it's first laid out by David Leach. It would occur in 4 phases. And you'll notice on the slide that we'd really hoped to be developing models of excellence for wide dissemination by 2011. We clearly haven't gotten there, but we have made progress. And it highlights how difficult and messy this can be. And there were a number of challenges in implementing the Outcome Project. Now, in 2001, these were the 6 general competencies that were launched. I hope by now you're all familiar with these, but I also know that some of these have been and continue to be quite challenging. In fact, implementation was hard and confusing. Educators struggled to understand how competencies translated into curriculum and assessments. And more importantly, educators and faculty lacked a shared mental model of professional development and also shared mental models of these newer competencies, such as systems-based practice and practice-based learning and improvement. Enter the milestones. One of the primary reasons the milestones were first explored was to create a developmental language, a narrative that would help faculty build these mental models. Believe it or not, the very first meeting to explore the possibility of milestones occurred in November of 2007 in Philadelphia with the internal medicine community. This community then published its first version of the milestones in JGME in 2009. And then there were a series of activities that occurred in other specialties such as surgery and pediatrics. And between 2010 and 2013, the ACGME made the decision to make them part of the next accreditation system, and all the specialties began work. In July of 2013, 7 specialties officially began using and reporting on the milestones. And one of the early adopters was emergency medicine, who actually did a really nice job in the creation of the milestones and had one of the larger proportion of community involvement of the first 7 groups to go. And so I want to really congratulate you on that as being one of the early leaders in this space. And as you all know, by July 2014, the majority of specialties began using milestones. So in that kind of brief history, let's take a look more specifically at competency-based medical education and define it, and why these milestones and competencies are important. Well, let's take a moment and reflect on what medical education has looked like the past year in the time of COVID-19. What we have learned in the past year is that the pandemic has shown reliance on proxies, such as just time, is actually pretty shaky. That a number of proxies or rotations or things we depended on were not available. We actually released guidance on assessment during the pandemic last September, encouraging programs to put a heavier emphasis on assessments where they could and not rely on these proxies. We also learned that assessment matters a lot, because without good assessment, it's hard to make good judgments if you have this over-reliance on proxies. It turns out that CBME, or competency-based medical education, not a new idea. It's been around since the 1970s. This is a really important report from the World Health Organization led by Bill McGahey of Northwestern University. And they said that the intended output of a competency-based program is a health professional who can practice medicine at a defined level of proficiency in accord with local conditions to meet local needs. In other words, it's about the populations you serve. And one of the primary principles that was embedded in this report was the use of mastery approach to training, not the use of proxies. Fast forward to 2010, at the same time of the Lancet Commission report, a group of international educators got together, led by the Royal College in Canada, and they updated the definition, if you will. And they defined CBME as an approach to preparing physicians for practice that is fundamentally oriented to graduate outcome abilities and organized around competencies derived from analysis of societal and patient needs. It de-emphasizes time-based training and promises greater accountability, flexibility, and learner-centeredness. This is not to say time doesn't matter, it does. But in a CBME or outcomes-based system, time is considered a resource, not the intervention. And competencies become one of the mechanisms we use to define the outcomes. More recently, Elaine Van Mel has extended the concept and explored what are the core components of a CBME approach. As I just mentioned, an outcomes-based competency framework is really important to define those educational outcomes. But then we have to attend to the progressive sequencing of those competencies in a developmental fashion. And what flows from that is that our learning experiences and our teaching has to be tailored to those competencies to meet those societal needs. And all of this must be undergirded or supported by programmatic assessment. Now, you may look at these core competencies and say, core components, and where's the evidence for these? It turns out they're deeply evidenced in form. If you read Elaine's paper, published in Academic Medicine in 2019, you'll notice that there are multiple theories and empiric evidence that undergirds or again supports each of these 5 components. And one of the key components, again, is the competency framework, which is a way to operationalize outcomes. And so it's important as we think about CBME to recognize that competencies are the framework we use to define and explicate those educational outcomes. Competencies help define the core abilities of the physician and are further specified for specialty disciplines through the milestones, so that we can make them more contextually and content specific for your specialty. I would say the following: love them or hate them. The 6 general competencies have required GME to focus on important abilities long neglected in medicine, such as quality improvement, patient safety, interprofessional teamwork, care coordination, to mention just a few. But equally important is to recognize they do not represent the totality of a discipline or all of professional development. Your experience, judgment, and wisdom still matter a lot, but it should be informed by the evidence and the theories that underlie competency-based medical education. And the other question you might ask yourself, if not an outcome focus and competencies to specify education outcomes, then what would you replace it with? I have little doubt in the future that'll happen. But right now, this is where we are in our developmental journey, and we're learning how to best apply these to get those optimal educational outcomes, which then should translate into optimal clinical outcomes. And so, as I've alluded to, in order to implement CBME, you have to think developmentally. And this has been a bit of a challenge for us. Let's explore this in a bit of detail. As I mentioned, there's a number of theories that really support the importance of an outcomes-based approach. One of those was deliberate practice, the work of Anders Ericsson over decades. We sadly lost Anders last spring unexpectedly. But back in 1996, in an important paper, he said that deliberate practice represents individualized training activities, especially designed by a coach or teacher, to improve specific aspects of an individual's performance through repetition and successive refinement. Deliberate practice is planned, longitudinal, effortful, and goal-directed. If you want to read a kind of very accessible version of this, I strongly recommend his 2016 book, Peak. And one of the things he points out in this book that's so important that ties back to the milestones is that you require a field that is reasonably well developed, and there must be clear mental representation of the task of the field in order for folks to understand how to get to that outcome, but also to have teachers who can provide the practice activities that are necessary to help learners improve their performance. And one of the challenges we've had in medical education is that we often don't have shared mental models around those key tasks within various specialties or across disciplines. Another really important body of work is called mastery-based learning, and I alluded to this from Bill McGahey. In this approach, excellence is expected and achievable by all learners who are able, motivated, and work hard. Little to no variation in measured outcomes is the expectation. And I think that's a question of work we still need to do. What is unwarranted variation within our educational programs at the current time, and what is acceptable variability? Third, learning in any domain depends on learning a sequence of less complex components. And finally, if learners receive optimal quality of instruction and learning time required, the majority of learners should attain mastery. In other words, a high bar. We're not shooting for the floor here. We also know that learning curves are sigmoidal. They're not a nice 45-degree incline. This is a really wonderful article from Martin Pusek that really highlights the point and is overlaid onto this learning curve, the Dreyfus stage model development, which I'll say more about in just a moment. But we have to recognize that when folks are with us during the residency program, whether it be a 3 or 4 year emergency medicine training program, they're on the steep part of that curve. And our goal is to get them to proficiency. This is just an example of what learning curves look like in real life. If you look on the left at the group average for these 18 pediatric residents that were engaged in an experiment exploring reading pediatric ankle radiographs, you'll notice the early part of that curve is in fact quite steep, and then there's gradual improvement. But if you look to the right, you'll notice the individual patterns are pretty stunning. They're all very different. Some are pretty good and reach a pretty high level of performance quickly, but then they plateau. Others struggle even after 200 films to get to 2/3 accuracy. This is another example from colonoscopy, wonderful work of Bob Sedlak, that shows that, and really to reach proficiency, you have to do 400 of these. Stop and take a moment to think about that. And in fact, in Bob's other work, he's found the range could be anywhere from, say, 175 to 600, depending on the learner. Do we currently have educational programs that can adapt and adjust and tailor and sequence things for learners who may be on very different curves? And then, as I mentioned, this is the stage model development that was created by the Dreyfus brothers, Hewlett and Stuart Dreyfus, many years ago. It's not a linear process, but it simply calls out these important stages, and you can advance at different rates. You might even regress, but it's the stage model development that informs the milestone framework or rubric. In fact, Hubert and Stuart Dreyfus were part of the original work group that created the 6 general competencies. They served as consultants to that original work. And then I love this quote from Dr. Harry Jason and why it's so important for us to think developmentally. He said, by making time a constant, we make achievement a variable. And I'll let you think about that for a moment. How do we make sure, by using time as a resource, that we make sure people attain that mastery level of performance, regardless of where they start? So let me shift gears a little bit and show you what we're trying to do with the ACG-ME to support development, and show you some work around milestones and learning analytics. It's important to recognize that this is the GME assessment system. I work on the right-hand side of this diagram in the accreditation oval. Our primary constituency is the public. But here's the bottom line. We're only as good as what happens inside that rectangle, and that's you. It's your combination of assessments using programmatic assessment that generates, we hope, rich narrative as well as quantitative data that comes to a clinical competency committee that then uses that data to synthesize a developmental judgment. Those judgments should then be fed back to the residents so that they can generate individualized learning plans, as well as back to the program and faculty to help them continually get better. As you notice, this is just a constant loop. In this system, residents also have to be active agents. We have to work with them. Assessment too often is something we do to them instead of something with them. And I encourage you to rethink their role in the assessment system. But ultimately, you do have to make a kind of final entrustment judgment that is high stakes. And you want to make sure that your resident who's reaching graduation is truly ready to provide care in an unsupervised fashion. So when we think about that programmatic assessment piece, which you remember is one of the 5 core components from Elaine Van Mel, these are the minimal assessment components that are necessary to be successful. That includes faculty evaluations, direct observations, multi-source feedback is essential for professionalism, interpersonal communication skills, particularly interprofessional teamwork skills, and systems-based practice. We must begin to use more audit and performance data. I know that's difficult and it's messy, but without including it, you really can't learn practice-based learning and improvement systems-based practice. And then where applicable, simulation and in-training exams can be really helpful. But these are kind of the minimal components that have to be part of an assessment program. And that all has to come together, guided by the milestones, to integrate your curriculum and assessment and to guide that resident on their journey to reach proficiency. Remember, that's the recommended goal. Level 4. It is not a requirement, it's a recommendation. And our hope is you'll use that data to constantly help your residents refine the learning plans and trajectories to help them reach that goal in each of the sub-competencies. As you know that there's a new set of milestones coming. This is an example from Milestones 2.0. This is Systems-Based Practice 3, System Navigation for Patient-Centered Care. This is honestly one of the more challenging ones, but we also know from research it's very important. We hope that by creating these kind of constant threads, that this will get easier to use over time, but we know there's still a lot of learning. But one of the things I want to point out is that when you're working in your CCCs, don't pay attention to the numbers. I just blanked them out on purpose. Instead, what we want you to do is you're talking about your learners, focus on the narratives. That's where you want to figure out where that narrative best matches your learner's performance. The numbers are nothing more than a code. That's it, just a code. They're nice, we can use them. We can use them for quantitative analytics, but in the end, if they're not associating with any meaningful description, they're not very useful. And just a reminder that level 4 is the recommended goal of proficiency, not a requirement. Because emergency medicine's been an early adopter, we've been actually able to look at your data and begin to work with it from a learning analytic perspective. So assuming that those codes are accurate, and we realize that's still a learning process in and of itself, we can map out every single trajectory of every resident across every program in the United States. And you'll notice that in this example, there were 20% of residents at the time of graduation, the very first cohort who used the milestones were judged within the subcompetency not to have reached level 4. The question becomes, can we identify them earlier so that we can provide that information back to you as simply a guide, a tool to help identify folks who may need a little bit more help? That's the whole purpose of analytics. And so we now have these in the national reports. You can pull these up on our website that at any given point in time for any given subcompetency, the example here is patient care 9, you can get a kind of rough estimate of the percent risk they will not reach level 4 by the time of graduation. So in this example here with a year to go, if somebody's judged to be at level 2.5, they have about a 35% chance they won't reach the graduation target. What we want you to do is just ask good questions. What do we need to do to help this individual in this competency? And this is just the data from last year, obviously disrupted by the pandemic. But these are tools we hope you'll consider using that's now been enabled because of the fact you're reporting this data on a national level. We can begin to do these type of analytics. And so, as I said, if you detect these patterns, the continuous quality improvement question is ask why. Is further assessment or clarification needed? Or is this just simply an expected pattern in your program based on curricular design? And how might you use these to help the learner complete an individualized learning plan? Do you need a formal remediation plan, or maybe it's just 1 or 2? The purpose of these analytics is to facilitate and support professional growth and improvement, not to punish, but to support professional development to help people reach those goals. And so where do we go to next? I'd like to end with just a few thoughts on how do we accelerate the journey to outcomes-based education. This has been something that's been heavily discussed as a result of the pandemic. I'd make just a few comments. First, embrace a systems thinking mindset. Second, think developmentally in curricular design and programmatic assessment. Remember, transformation is an iterative process. It'll be ongoing, and it's something that we'll always need to continue to do. Third, engage learners as active agents in their assessments. Have them become your partners. Have them work with you to co-produce assessments and improve the assessment program. We need to increase attention to the other competencies. They matter, and they affect clinical and educational outcomes. I think we've reached a stage 20 years in where we just simply can't continue to ignore them. Again, recognizing that they're difficult, but we've got to advance assessment and learning in those other competencies. And then finally, I just want to make you aware that there's a lot of resources available on our website. We have a number of guidebooks. They've all been updated, and we have 2 new ones, an implementation guidebook and an assessment guidebook that are now out. We have faculty development and assessment courses that run throughout the year. They've been both virtual, and we hope to return in person in 2022. We also have 2 open access assessment tools that you're welcome to use. Again, they're free. One's in direct observation, and one is a multi-source feedback tool for interprofessional teamwork. And so with that, I'm just going to say thank you, just briefly show you my email, and then I will come off screen share. And I really appreciate the opportunity to be with you today, and all the best on the conference. Thank you.
Fantastic presentation, Dr. Holmboe. Got a question for you. You know, competency-based education has been something that the emergency medicine community has been talking about for quite some time. You know, as we know, the Outcomes Project came out back in 2001. But one of the things that I'm really struggling with, and I'm hoping you could kind of comment on, is, you know, how do we go from what we have right now, which is really a time-based education, to competency-based education?
It's a great question. It's one that comes up often. I think we're at a stage where I would use what we call a hybrid model. I don't see us having time variable in the near future where you graduate early or you graduate late. I think what we can do is use the principles of CBME within the time we have in order to advance training. And that's part of the reason why I emphasize time as a resource instead of time as an intervention. I do think that there's things we can do better, even in the confines of a 3 or 4 year program. We may get to time variable. There is a number of folks not interested in studying it through kind of experimentation. And ACGME has a pathway to do that. It's called the Advancing Innovation and Residency Education Pathway. We welcome submissions to that. But as I think, for the next, honestly, 3 to 5 years at a minimum, what we need to do is to figure out how to advance education and really, as I said, accelerate, focus on some of these other competencies like systems-based practice, practice-based learning and improvement, interprofessional teamwork, and the like. I think if we put our efforts there, that to me is more important than trying to, quote, rush to get to time variable. I don't see that as the primary outcome for a CBME approach.
Thank you. Another question, competency-based outcomes really seem to rely heavily on judgment of faculty and mentors.
Yep.
How do we train our mentors to assess in a fair and unbiased fashion?
Yeah, great question that could take hours. So this has been a deep area of interest. We've been doing a lot of research over the last 15 years in direct observation. I think first and foremost that one of the things faculty can do is make sure they themselves have really elevated their own competencies, in the things that they teach. We have found that the primary frame of reference faculty often use to judge residents is self. So if that's the case, the more that they can do to make sure they themselves have the requisite abilities, that's going to enable them to transfer, if you will, or help others reach that target. The second, I think we need to do more work on what I alluded to earlier around shared mental models. Do we all have a shared idea of what the outcome actually looks like? So when we say certain things, is our conception of that the same? We know in medicine that actually has been a real challenge. I had a chance to actually talk with Anders Ericsson about this a few years back, and he's worked in a number of different professions and fields. And one of the things that really struck him was the lack of shared mental models in medical education. For something so complex and sophisticated as medicine, he said people had a very hard time, kind of coming up with that. And so I think there's work to be done there. And then the third, there are faculty development techniques to help build those shared mental models. And also to get us to recognize, what really high-level skills look like. Bill McGahee's work in mastery-based learning is a fantastic example where they've shown that using that technique, particularly starting with simulation and then moving into practice, it actually translates into better patient outcomes, fewer complications, for example, in procedures. So I think we're still learning on this journey, but those are some of the things we can do now. And that takes conversation, faculty really working on defining those educational outcomes within their context and making sure that they, share what those differences are. The last thing to get to your point is we just kind of have to continually address the issues of bias. It's a real thing. But that takes, kind of self-awareness, being able to, look at your data as part of the CQI process and look for patterns that may suggest things like gender bias, or do we see bias based on race and ethnicity? We know, for example, in a study done in emergency medicine, that there appeared to be a separation in the ratings faculty gave of men and women toward the end of training in a study done by Dial. The good news is we don't see that national milestones data, but it does raise questions that we need to continually use our data for improvement and look for those patterns that suggest things like bias might be present. So those are just some ideas, Susan.
So I've got one final question for you.
Sure.
You made mention of COVID-19 and the pandemic and some recommendations that came out from ACGME around that. What do you think the lasting effects will be on kind of emergency medicine education from the pandemic?
Yeah, I mean, your specialty has been so deeply impacted by this pandemic. I mean, you're one of a handful of specialties that's been, hit the hardest, if you will. And so I think one is to harvest the lessons, from having to work, with a crisis. As the saying goes, never waste a good crisis, and take the lessons from that. I think emergency medicine will not only be looking at itself, so to speak, and moving those lessons forward. But I think it has a lot to offer other disciplines as well because of the adaptations and flexibility you had to basically implement in order to take care of patients and yet maintain education, at least at some level. I think the other is to recognize it also exposed some areas that are still deficient. And so we should take that opportunity to improve education in areas that maybe weren't paying enough attention, and to recognize things like, dealing with systems. Issues of care coordination are really, really important. And the pandemic exposed those didn't always work very well, particularly in the early phases. They got better as people learned. But I do think there's opportunities there. Emergency medicine has been a leader in many ways. Even though you're young specialty, I think some of that youthful vitality has also led to more an embracement of innovation. Like I said, you're one of the early adopters of the milestones. You have some of the first studies published in validity of the milestones. I didn't cover that, but emergency medicine published some of the very first ones. I would embrace that kind of innovative spirit within the discipline, take the lessons learned not only for yourself, but also share them across other specialties.
Well, thank you again for imparting your knowledge with academic emergency medicine community. It's a wonderful discussion. Thank you.
Thanks for having me.
Our pleasure.
And our first presentation is titled, "Does Problem Representation by Third-Year Medical Students Increase Diagnostic Accuracy?" Presented by Dr. Jake Valentine, Johns Hopkins University. Dr. Valentine, please begin when you're ready.
Thanks for the introduction, Dr. Beam. Again, I'm Jake Valentine, presenting my abstract, "Does Problem Representation by Third-Year Medical Students Increase Diagnostic Accuracy?" I have no disclosures, and wanted to give a quick thank you to our team. Dr. Young's our clerkship director, and my personal mentor, Dr. Tackett, we recruited from the internal medicine department, and appreciate his statistical expertise. Dr. Board, our assistant clerkship director, and my colleagues, Dr. Bada and Dr. Zink, who will graduate with me in July. I'm sure will go on to fantastic things in academic emergency medicine. I've got three objectives for the presentation. The first is to define problem representation. The second is to analyze the abstract within the framework of cognitive learning theory. And the third is to contrast the results with previous research on problem representation. So what is problem representation? It's essentially a single sentence summary that includes the most defining discriminating features of the case. So on the left, if we have what the patient might offer in layman's terms on a HPI, and on the right, you have the physician who, using problem representation very astutely, can condense the entire presentation into acute atraumatic mononephropathy, and may have a very limited differential for those things, as opposed to something more general like just knee pain. Within the broader scope of adult learning theory, I think problem representation probably falls under the learning theory of cognitivism. Cognitivists really like to compare the human mind to computer processing. So if we have a very limited short-term working memory for computers, we'd call that ROM. We have a much broader long-term knowledge base, which on computers we'd call that a hard drive. Problem representation hopefully helps with both things. One, because it allows us to organize that differential diagnosis to that single sentence summary rather than having to think of the entire HPI. And then also probably elicits buzzwords and creates knowledge organization structures that promote long-term knowledge retention. And just kind of a schematic of where we are, we would be under the category of adult learning theory, scrolling down to cognitivism, subcategory of knowledge organization, and here we arrive at the topic of our day. So what is known about problem representation? I just want to go over briefly the design of two previous studies that really inspired our project today. So the first study is by Chang et al. You can see the title of the study at the top. But basically what they did is that they exposed a group of students to a clinical vignette and had the students examine and reason through the case via stimulated recall. So they asked the students not only what they thought the diagnosis might be, but also what the justification of those diagnoses would look like as well. They had trained transcribers who were familiar with problem representation take the justifications that the students were making and translate them over into what they viewed as problem representation statements. The finding from this study was that students who had better problem representations had higher diagnostic accuracy. So there was a correlation there between problem representation and diagnostic accuracy. Follow-up study by Nendes and others promoting diagnostic problem representation had a more experimental design where you had a control population and intervention population. The intervention was a brief educational intervention on problem representation. And unfortunately, it showed that the students that were taught problem representation seemed to be pretty well versed in it. They made pretty elaborate problem representations. They used something called semantic qualifiers, essentially your adjectives in that old CARTS mnemonic, like your onset, location, duration, timing, severity, and so forth. But despite being good at problem representation, it didn't help them at all when it came time for diagnostic accuracy. So they found no correlation between problem representation and diagnostic accuracy. Obviously difficult to unify those two contrasting findings. We think that probably it's a chicken or egg phenomenon in the first study that showed correlation, in that students weren't necessarily using the problem representation to arrive at the diagnosis. They already had the diagnosis in mind from pattern recognition or perhaps some other cognitive strategy. And then when prompted, they offered a kind of retroactive, oh, well, I guess I think it's a septic joint because it was a XYZ, being that problem representation, being that acute atraumatic mononephropathy. So this brings us to our study today. What did we do differently, and how did we try to circumnavigate some of that chicken and egg controversy with problem representation diagnostic accuracy? So we elected to do a quasi-experimental design where we would have a group of students that were our control, and then we would have our intervention group. We took all of the third-year medical students, there's about 110 students in total, who were completing the end of the third year objective structured clinical exam, which is essentially a step 2 CS equivalent within our institution. The intervention was exposing the students to this problem representation before they were prompted to write their top diagnosis or top 3 diagnoses. So each student would rotate through each one rotate through 10 different stations, and they would do the HPI through their standardized patient. And at the end of that, would have a write-up that included giving the top diagnosis and top 3 diagnoses. And again, the intervention was exposing them to this prompt. What we wanted to measure first and foremost, our primary outcome, was whether the students in the intervention group had higher rates of the correct answer in that top slot for their top diagnosis or within the top 3 slots. Our secondary outcomes looked at the note score between these two groups. We elected notes to look at note score because we thought it might show a larger difference because that's essentially the MDM component of the exam. And our third outcome would be correlation between better problem representations within that intervention group and the 2 measures already listed above. So what was the verdict? Well, it didn't work. You could see there was essentially identical between both groups in the percent listing the correct diagnosis in the top slot. Essentially identical percentage within the top 3 slots and a pretty identical note score between the 2 groups as well. And of course, none of these approached a p-value that would suggest statistical significance. Well, at least did students who had better problem representations have better diagnostic accuracy? No, that didn't seem to matter either. Again, none of these p-values approached 0.5. There was no difference in the percent of the students who had a summary statement score of 0, 0.5, or 1, with 0 being the worst summary statement, 1 being the best summary statement, and whether they got the diagnosis correct in the top slot, top 3 slots, or whether they had a better MDM discussion during the write-up of their note. The summary score wasn't something that we just made up. We elected to use a previously validated rubric that was from a study from Dory and others. And it wasn't particularly complicated. This is the sum total of the rubric. And just kind of getting to the bottom line, I don't think that this factored into a lack of correlation between problem representation and diagnostic accuracy. We had fairly good inter-rater reliability, and the other measures of validity were kind of well represented in the study by Dory. So what gives? Problem representation seems to have quite a lot of promise from a theoretical background. It's shown conflicting results in kind of in vivo studies here, but it's fallen short again in our study, which had a fairly large representations, 100 plus students, 1,000 plus cases. I think overall that we're looking at a necessary but not sufficient issue, where sure, problem representation helps, but by itself probably is not powerful enough to show a difference. There's still alternative cognitive processing strategies that are working in conjunction with problem representation. That's your pattern recognition, that's your scheme inductive reasoning, your hypothetical deductive reasoning, your concept mapping, your illness scripting, your dual process thinking. I think just focusing on the one narrow subject of problem representation probably ought not to be expected to be sufficient enough to show a difference. We were tempted to suppose that perhaps the novice learners were ill-equipped to benefit from problem representation, not being particularly familiar with the construct. But we looked a little bit deeper into the research and found that really doesn't correlate with what we already know on the topic. So there's just been prior studies where learners are presented and learners that were at the same level, like around the MS3 level, they were presented with a preformed problem representation versus an unabridged history and physical information. And the ones who were presented with problem representations already constructed for them do better, and that's been well replicated. So perhaps it's a issue in constructing problem representations kind of at the learning level here. Kind of either way, I think the problem that we're running into is whether we ought to continue to target an isolation of problem representation as an opportunity for curriculum intervention. Which brings us to our final slide for future directions. I think we advocate overall for additional research on curricula still targeting this skill because it has shown value in those other studies. I think that the biggest limitation in problem representation is not to expect that it is by itself sufficient enough to have diagnostic accuracy outcomes or patient-oriented outcomes, which is an issue in education research in general, because there are just so many factors that go into clinical decision-making that it's a very difficult construct to measure. So perhaps going forward, combining problem representation within the broader subject of data abstraction using related tools like concept mapping might ultimately be a better focus for future investigation and intervention. But I guess that is to be seen. So thank you for your time, and I'll pause now to take questions from our moderators.
Thank you, Dr. Valentine. As questions are coming in, I will read them off appropriately. Our first question is, what is the relationship between the cognitive processing strategies you mentioned on your slide with the computer folders?
Thanks, Dr. Beam. Excellent question. I think overall, these are all different ways of kind of knowledge organization and data abstraction. Can you look at the multitude of patient presentations and HPI information and find that common element where you're able to have this intermediate, not quite differential diagnosis, but at least I know what we're talking about. At least I know I'm talking about acute atraumatic joint pain. At least I know I'm talking about shock, and I'm going into the 5 different causes of shock. So I think the ability to have that intermediate to pull from the knowledge organizations is common to each one of those categories listed on that slide.
Okay. Our next question is that could the problem be that the missing feature in the problem representation is that third-year medical students do not have the gestalt, i.e. that their hard drive isn't ready to process the RAM?
Yeah, we thought about that a lot. I think I would counter that with they don't have the gestalt to use pattern recognition. So they have to rely on something else. They have to rely on a problem representation. The only alternative is what we would call hypothetical deductive reasoning, which is reasoning backwards, which in emergency medicine, we do this all the time. Like we see chest pain, we've got our 5 emergency causes of chest pain, and we just kind of like play a guess who game, narrowing it down to which of those 5 it might be or might not be. And then there's a catch-all basket of the other ones that we, essentially would feel safe and comfortable discharging home. So I think they're forced to use problem representation. And I would advocate that this is the exact population that you want to target this intervention on.
Another question that's coming in is, one of the things that's happened over the last 25 years is that clinical decision rules have helped come to risk stratify patients. Do you think that this plays a part in the difference of not finding a difference in outcomes in your patient or in the study that you have?
Well, that's an interesting question too. I can probably take the first part of it. We're seeing more and more clinical decision tools, but it's in a very still narrow field of medicine, a narrow number of diagnoses that fit that, where you have all of this robust data to know what the pretest probability is, so that the rest of it's relatively easy, right? We can get our positive and negative likelihood ratios and then spit out the post-test probability and then figure out what our risk tolerance is going to be, and whether that qualifies as a diagnosis or ruling in and ruling out. So I think that lack of the pretest probability still requires so much kind of like, I'd say Gestalt knowledge, but of course it's this kind of assumed and unconscious building of that pretest probability that really just comes with experience.
Okay. Our final question is, what is the relationship between how do you assess clinical reasoning? How do you know if an intervention to teach clinical reasoning worked?
Again, another thing that was a limitation of the paper and something that we thought a whole lot about. It's tough to know if the clinical reasoning was correct or not. There's reasonably good data that shows that we don't even have particularly good insight to our own clinical reasoning when we do like a stimulated recall and think aloud exercises, kind of compared to a video presentation. There's a lot of discordance between what we retrospectively think that we were doing versus what we probably actually were doing. So we don't even have great insight to clinical reasoning. And then to know whether there's a particular reasoning strategy that works or not, I think the key at the end of the day is going to be to link educational outcomes to patient outcomes. So not how well they did on the test, but are we getting antibiotics in on time and recognizing sepsis? Are we finding the STEMIs and the subtle STEMIs at an appropriate time? And that's going to be a key for medical education research going forward, is to link those two and kind of converge education with continuous quality improvement.
I think that you hit the nail on the head with that one. That's the key. That is the key. Well, thank you, Dr. Valentine. Great presentation. And
thanks,
our next presentation is titled Racial and Ethnic Disparities in the Prehospital Management of Non-Traumatic Pain, presented by Angie Aceves, McGovern Medical School of UT Health at Houston. Dr. Aceves, please begin when you are ready.
Hi, thank you so much for that introduction. My name is Angie Aceves, and I am an incoming intern at the UT Health Emergency Medicine program. And I would like to give a special thanks to Dr. Hubinger, who has been a great mentor throughout this whole project. So our abstract is titled Disparities in the Pre-Hospital Non-Traumatic Pain Management. Remley Crowe is an employer of ESO, and all other authors have no financial disclosure. The relief of severe and acute pain has been recognized as a fundamental human right by the World Health Organization. However, racial disparities in pain control have been identified in the emergency department and for traumatic pain. A 2019 meta-analysis in the American Journal of Emergency Medicine showed that Black patients were 36% less likely to receive any analgesia when compared to non-Hispanic whites, while Hispanics were 30% less likely to receive analgesia. Pain management disparities are also strongly associated with opioid medication with disparities in opioid medications for minorities. That same model showed that Black patients were also 35% less likely to receive opioids. And a similar study in the Journal of Pain showed that while opioid analgesic prescribing has dramatically increased over the last decade, there has been a disproportionate growth toward Black patients and non-US born patients. Over the last few decades, pre-hospital transportation has also drastically grown. An estimated 15 million patients required emergency medical services annually, with 20 to 30% of those reporting experiencing moderate to severe pain. Early pain management and pre-hospital analgesia administration practices have shown benefits in patient satisfaction and long-term outcomes. Although prior research has identified disparities in the pre-hospital analgesia for traumatic pain, little is known about non-traumatic pain. So we sought to evaluate racial and ethnic disparities in analgesia given by EMS for non-traumatic pain using a large national data set. For our analysis, we utilized the 2018-2019 ESO dataset. This is a national pre-hospital electronic record provider used by nearly 1,300 EMS agencies in the US. We included all transported adult non-traumatic encounters for pain complaint, and we excluded those in age under 18 and over 120, those with missing data, those who were not transported, that which occurred in a hospital or emergency department, and those who were given aspirin for chest pain. In order to define our study variables, we first stratified subjects into racial and ethnic categories based on paramedic provider reported race and ethnicities. We included non-Hispanic Latino whites, Black, Hispanic Latino, Asian, Hawaiian or Pacific Islander, and Native Americans. Our outcomes were those receiving pain medications during their EMS encounter, those receiving opioids during their encounter, and receiving pain medication within 30 minutes. For our analysis, we built a mixed effect logistic regression model. We evaluated the association between race and ethnicity with our outcomes, and then we fit agency as a random intercept. We then adjusted for any possible confounders. So these results are updated from our original abstract, but our primary conclusion and results do remain the same. In our adjusted outcomes for Black patients, in our unadjusted outcomes, we found that Black patients had the lowest rate of administration in pain medication, while Hispanics had the highest rate. For opioids, Black subjects had the lowest rate of administration, while Hispanics had the highest. And Hawaiian or Pacific Islander had the highest percent of pain medication within 30 minutes. In our analysis of odds of pain medication administration compared to non-Hispanic whites, we found that Black patients were significantly less likely to receive any pain medication, while Hispanics were more likely. In our odds of opioid pain medication administration compared to non-Hispanic whites, we found that Black patients and Asian patients were also less likely to receive any opioid medications, while Hispanics were more likely. Additionally, we found that the odds of receiving pain medication within 30 minutes was higher for Hispanic and Pacific Islander patients, but no different for Black or other patients. So our study had some limitations due to the retrospective nature of the study. Evaluation of causality is limited, and there may be some possible confounders that we were not able to account for. And then for our time to patient analysis, we were reliant on the timestamp and entry, which is subject to some inaccuracies by provider data entry. Additionally, there may be a situation in which the provider is unable to tell the ethnicity, and we are reliant on the provider's interpretation. Our analysis found that Black patients were less likely to receive pain medication and opioids, while Hispanics were more likely to receive pain medications and opioids in a timely manner. And in conclusion, we identified disparities in non-traumatic pain medication administration. Thank you for your time, and I will now be taking any questions.
Thank you, Dr. Aceves. As the questions arrive, I will read them to you so that you can answer them. First question is, how did you arrive to 30 minutes for the time of administration?
Yes, so we felt that 30 minutes was a reasonable amount of time for pain medication to be administered. However, we could have also done anywhere between 20 to 30 minutes. I believe the average for ESO is time for pain administration is around 22 minutes.
Okay. Another question is coming in. Do you think that the Austin, Texas population density is able to be representative of the nation, or do you think that this would different based on different population densities?
Yeah, so ESO is actually based out of over 1,300 EMS agencies around the country. So it's not just based in Austin. And so it's definitely more regionally spread. However, if we were to just look at, for example, Austin or maybe a state more in the South that has predominantly a Hispanic population or another ethnicity, there is definitely room for there to be more disparities in a certain population.
Okay. What do you believe causes these disparities in pain management?
Sure. So our analysis was targeted at identifying these disparities, and we are still interpreting our results. And so that does fall out of scope of our research. However, there are a lot of different factors that could be responsible for these disparities. Some of these have been attributed to certain ethnicities being more conservative when it comes to opioids, whether it is for fear of addiction, developing tolerance. It could also be some cultures try to be more conservative in reaching out for pain. However, other studies have shown that even in student paramedics, race does tend to influence the pain administration. So it could also be interpreting certain ethnicities to have different pain scores. There could also be language barriers. So while we don't know one clear answer, we believe that is definitely for further research.
I think it goes to show that our healthcare system and us as a nation still has a long way to go to make sure that everyone treats each other as equal.
Absolutely.
So thank you for that great presentation.
Thank you so much for having me.
Thank you, Dr. Aceves. Our next presentation is entitled Emergency Visits for Non-Fatal Opioid Overdoses During the COVID-19 Pandemic Across 6 United States Healthcare Systems. Presented by Dr. William E. Soares III, University of Massachusetts Medical School, Bay State Campus. Dr. Soares, please begin when you are ready.
Thank you, Dr. Promise. It's an honor to present our research at SAEM. My name is Bill Soares. I'm the Director of Harm Reduction at Bay State Medical Center in Springfield, Massachusetts, and an assistant professor at the University of Massachusetts Medical School, Bay State. And as was mentioned, our project is entitled Emergency Department Visits for Non-Fatal Opioid Overdose During the COVID-19 Pandemic Across 6 U.S. Healthcare Systems. Our work is supported by a U-24 from the NIH Research Collaboratory and the NIH Common Fund, from a UH3 from NIDA, and for myself, a KO8 from NIDA. During the presentation, we'll be using QR codes to link to articles and additional information. For those who may be unfamiliar, simply scan the QR code with your phone camera, and you'll be directed to the article or website. For example, the following QR code is a link to the full text of our paper made available as open access by Annals of Emergency Medicine. Let's start with a case. 25-year-old is brought to the ED by EMS for a suspected opioid overdose. He's found unresponsive by bystanders and administered nasal Narcan with improvement in mental status. Now, as the chair of your emergency department, you've been trying to incorporate medication treatment for opioid use disorder, including buprenorphine, into your ED practice. However, it's during the COVID-19 pandemic, and overall, ED volumes have fallen. And your question is if you're seeing fewer patients with opioid overdose, and really if medication treatment should be a priority right now. So as background, people with opioid use disorder have been exposed to unique vulnerabilities due to COVID-19, which include interruptions in treatment, social isolation, and alterations in the illicit drug supply. The emergency department serves as a critical treatment access point for patients with opioid use disorder for two reasons. First, a non-fatal overdose is the strongest predictor of a future fatal overdose. And second, medications like buprenorphine save lives. This is a study of patient mortality following an index emergency department visit for a non-fatal opioid overdose. The x-axis is time in months from the index overdose, and the y-axis is cumulative mortality. Now, the solid line going up represents the percent of annual mortality of patients not on medication treatment for opioid use disorder, while the lines with symbols represent those on medication treatment, including methadone and buprenorphine. You can clearly see those engaged in medication treatment for opioid use disorder had about half the annual mortality rate, decreasing from 5% to 2%. Simply put, medications like buprenorphine save lives. However, we also know that during COVID-19, ED volumes drastically decreased for other medical emergencies. This figure shows decreases in ED visit counts across 4 healthcare systems during the first wave of the COVID-19 pandemic. The black lines and dots represent decreasing visits, and the light blue are the corresponding increase in national COVID-19 cases. Now, our gap in knowledge was if other medical emergencies were avoiding the ED due to COVID, perhaps the same was true for patients following an opioid overdose. Our research question, how has ED utilization following a non-fatal opioid overdose changed during COVID-19? We used a multi-center retrospective cross-sectional design in which we evaluated 25 emergency departments across 6 healthcare systems in the US and included adults who presented to a study emergency department between January 2018 and December 2020 with an ICD-10 diagnosis code corresponding to opioid overdose poisoning. In terms of outcomes, we evaluated weekly opioid overdose ED visit counts and rates per 100 all-cause visits for 2020 and compared them to 2018 and 2019 as historical controls. For analysis, we used Poisson modeling with fixed effects, lowest plots of observed and predicted overdose counts, as well as epidemiological outbreak detection using two-sided Q-sum approach. Now, I am forever grateful for Dr. Molly Jeffrey, one of our senior authors and statistical genius, for her incredible work on the paper. If you are interested in learning more about our statistics, I urge you to scan the QR code, which will lead to a Google document of an email exchange where Molly used lizards and salmonella to explain to me in layman's terms what exactly is an epidemiological outbreak detection analysis. Now, I have to mention, part of the reason we were able to complete our project in such a timely fashion was thanks to the groundwork established by the EMBED trial. EMBED is a multi-center pragmatic trial led by Drs. Ted Melnick and Gail D'Onofrio, evaluating the impact of a clinical decision support tool to promote ED-based buprenorphine. Now, as a study group of 5 healthcare systems, we've been working together for the past 2 years. This meant that mechanisms that sometimes delay research, multi-center IRB approval, data code creation, collection, were already established, allowing us to quickly pivot to study the impact of COVID-19 on patients with opioid use disorder. With regards to results, 25 emergency departments accounted for over 1.3 million combined annual adult ED visits. Of the 25 EDs, 22 were classified as urban or suburban, 17 were community sites, and the historical estimated community overdose death rate ranged from 12 per 100,000 in Wake County, North Carolina, to 45 per 100,000 where I practice in Hampden County, Massachusetts. For our primary outcome, despite a 14% decrease in total ED visits in 2020 during COVID-19, rates of opioid overdose per 100 all-cause ED visits increased 29%. Even more striking, the overall weekly visit counts increased 11% across all sites. Our first figure represents excess overdose visits during COVID-19, stratified by healthcare system. The y-axis is ED overdose visits, and the x-axis is months in the year 2020. Now, the dashed heavy black line are the predicted overdose visits based on the historical data, And the solid black line are what we actually saw in the 2020 rates. Now, to help interpret excess versus reduced overdose visits, we used shading. So the dark gray represents the excess overdose rates, and the light gray is reduced. You can see that every system experienced increased opioid overdose visits from the predicted historical controls at times during COVID. Our figure 2 is the epidemiological outbreak analysis, again, stratified by healthcare system. The dark gray bars represent an outbreak alert, triggered for multiple values above the 95% prediction. 4 of 6 sites, Yale, University of North Carolina, University of Alabama, and University of Colorado Health, triggered outbreak alerts for ED opioid overdose visits during COVID-19. Now, our study has limitations that must be considered. First, the EDs included in our study were not a nationally representative sample, and results may vary, especially in different geographic locations. Second, given limitations of our study design and differences in our electronic health records, we were unable to capture other predictors of opioid overdose, including community prevalence of fentanyl, polysubstance use, and co-occurring mental health diagnoses. However, our study also has unique strengths, including 2 years of historical data to provide a more accurate representation of historical trends. We also used ED-based overdose diagnoses made by clinicians rather than proxies such as Narcan administration by EMS. Finally, our EDs were diverse in location, type, and community prevalence of drug overdose death, hopefully adding to the generalizability of our results. Now, new data emerges every day highlighting the worsening opioid epidemic underlying COVID-19. The CDC estimates a nearly 30% increase in drug overdose deaths over the past year, ending in September 2020. Our study adds to existing literature that despite decreased visits for other medical emergencies, we as emergency providers are seeing an increased proportion of patients with opioid use disorder, likely due to an exponential rise in opioid overdose rates in our communities. For the emergency department clinicians and administrators, it is more critical than ever to engage patients with opioid use disorder and medication treatment, including Suboxone. For those who might not be aware, HHS removed the training required for the DEAX waiver, streamlining the process to prescribe Suboxone. More information can be found at the California Bridge website, which the QR code links. Additionally, if you have your DEX waiver but are unsure how to engage in buprenorphine, here are a few tools, including the MD Calc Embed Clinical Decision Tool and free downloadable ED buprenorphine algorithms and patient discharge instructions from Foamcast. Now, for those in attendance who are our national leaders, COVID-19 has exposed inequities in our treatment of patients with addiction. Continuing to advocate for removal of barriers to treatment, including the expansion of Medicaid, easing restrictions on methadone, and enhanced telemedicine may all help to offer life-saving treatment to more of our patients with opioid use disorder. My thanks goes out to the entire Embed team, especially those who work to make the study possible. For those who are relatively new to research like myself, working as a site PI on a larger study group of peers and mentors has been incredibly rewarding and has allowed me to expand both my knowledge and impact as a researcher and clinician. If you'd like full access to our paper, it was made available as open access in a preprint form by Annals of Emergency Medicine, which can be found using the following DOI or QR code. Included are the references to our study, and I'd be happy to answer any questions. Thank you very much for your time.
Dr. Soares, it looks like we have a few questions from the audience. The first is, how does your data on ED overdose visits relate to community overdose rates?
Thanks for that question. I appreciate that. You know, I want to say that it is very difficult to assess community rates of overdose, and there are a lot of different reasons for that. But I would really urge caution in translating any individual hospital's data on their overdoses into what's exactly happening in their community. That said, you know, when we look at what else has been published as far as other medical emergencies like myocardial infarction, stroke, appendicitis, we know that during COVID, all of those rates went down. And it's not likely that people were having less MIs. It is likely that people were scared and staying home with their disease, which contributes to excess mortality. So the really concerning part is that we didn't see that. What we saw was increased rates and even increased counts. which I think, and again, I believe that doesn't necessarily mean more people were just coming to the emergency department with overdose. I think that it means there was an exponential increase in our community because people were still, even if they had an overdose, were still hesitant to come to the emergency department after an opioid overdose. So it really kind of concerns us that we didn't see that decrease like we saw decreases in other diagnoses. And I think that lends to the possibility, combined with other studies, that really there has been an exponential increase in worsening in the opioid epidemic during COVID.
We have another question. Were you able to look at the proportion of visits that were first-time opioid ED visits versus patients with a previous history of opioid use?
That is another great question. And unfortunately, we were not able to look at that. And there were other variables as well that we would, kind of looking back now, I think for future studies would love to look at. The other big one was the impact of race and ethnicity. Race and ethnicity have emerged as really important predictors. The discrepancy and the worsening opioid epidemic in folks who are racial and ethnic minorities is really important. So definitely, I think moving forward for ourselves and for other people, thinking about those more detailed variables that can be studied to help us better understand how this epidemic has worsened for different populations is really important.
I have one final question for you. Were you able to analyze the subset of patients who were trying to commit suicide by overdose? If not, what's your opinion on that?
So that's another great question. And again, it is really hard, I think, in these retrospective reviews, especially of multiple healthcare system using ICD codes, it can be very hard to kind of get that granular. You know, my experience with patients who have an opioid overdose is in fact that by far the majority are not, right? These are people with a disease. These, just like everyone else, these are people that want to live. And it is these other factors. It is the changing illicit drug supply. It is the fact that with COVID-19, people are scared and maybe they're using alone rather than using with friends or other groups that they normally use with. I think those are much more likely contributing to the increased rates of overdose rather than people using it as a mechanism for suicide. But again, that is a question that I think will really take an in-depth analysis because it really has to get into kind of the details of the chart, which we were unable to do with this project.
Thank you, Dr. Soares. Our final presentation, entitled Venous Thromboembolism in Patients Discharged from the Emergency Department with Ankle Fractures. Presented by Dr. Grewal, University, Toronto. Dr. Grewal, please begin when you're ready.
Thank you, Dr. Promise, and thank you for the opportunity for presenting at SAEM this year. My name is Keerat and I'm an emergency physician at Mount Sinai Hospital in Toronto, Ontario, in Canada, and I'm a clinician scientist at the University of Toronto. And today I have the opportunity to discuss our study looking at venous thromboembolism in patients discharged from the emergency department with ankle fractures. Me and my study co-authors have no conflicts of interest to declare, and funding for this study was partly provided by CanVector. Now, ankle fractures are commonly seen and treated in the emergency department. As emergency physicians, we often apply splints or casts or air boots to treat these ankle fractures. Previous studies have shown that lower limb immobilization for various lower limb injuries is associated with an increased risk of venous thromboembolism, or VTE. However, these studies have had a wide-ranging incidence of venous thromboembolism. Anywhere from 4 to 40% has been previously reported. And this wide-ranging incidence is likely due to heterogeneity in these studies, including various patient populations, including patients who have undergone surgery and those who have not, those who are admitted to hospital and those who are not, and also including a wide variety of lower limb injuries. Therefore, thromboprophylaxis to prevent venous thromboembolism in patients undergoing lower limb immobilization for lower extremity injuries is not currently universal. In Canada, where I work, I would say the majority of emergency physicians do not offer thromboprophylaxis to patients they're treating with lower limb immobilization for ankle fractures. However, this might be in contrast to other jurisdictions that do offer thromboprophylaxis, as there are some risk scores that are available to identify people who may benefit from this. However, because we don't really know what the magnitude of risk of venous thromboembolism in patients with lower extremity injuries that require immobilization, and we don't really know who would benefit from thromboprophylaxis, I think this is the reason why thromboprophylaxis is not universally used currently. Therefore, the objectives of our study were to look at the 90-day incidence of venous thromboembolism in patients discharged from the emergency department with a closed ankle fracture that required lower limb immobilization. And we wanted to look at a specific lower limb injury, so we decided to focus on ankle fractures. Our second objective was to identify risk factors associated with venous thromboembolism in this population. And finally, to see whether patients with an ankle fracture had an increased risk of venous thromboembolism compared to other patients, we compared the hazard of venous thromboembolism in these patients to other control patients discharged from the emergency department. So we used a retrospective cohort study design using administrative health databases from Ontario, Canada. Ontario has universal healthcare coverage for medically necessary care. Therefore, these administrative health databases include the vast majority of healthcare in the province. And we included emergency department visits from 2013 to 2018. We included patients 16 years of age and older who were discharged from the emergency department with a diagnosis of a closed ankle fracture that were identified using ICD-10 codes. And we only looked at the first ED visit for an ankle fracture for each patient. We excluded patients who left the emergency department without being seen and those who left against medical advice. We also excluded patients who were admitted to hospital from the emergency department. And because patients who are on anticoagulation would not have the same risk as those not on anticoagulation, we tried to exclude patients who we knew were on anticoagulation. However, Ontario does not have universal pharmacare coverage, so we were limited to identifying anticoagulation use in those with government coverage, so it was limited to those 65 years and older. As a proxy for patients on anticoagulation, we also excluded those with a history of atrial fibrillation. For outcomes and analysis, so our primary outcome of 90-day incidence of venous thromboembolism, we define venous thromboembolism as a diagnosis of a PE or DVT in the inpatient, outpatient, or emergency department setting. And we use the cumulative incidence function, censoring for death if this occurred before the end of follow-up. For our second objective, looking at risk factors of venous thromboembolism, we used a Cox proportional hazard model where we looked at various variables that we identified a priori, including demographic factors, risk factors for VTE, and comorbidities. And we censored patients at 90 days or death. And finally, for our last objective, comparing the hazard of venous thromboembolism to matched controls, we compared the risk of venous thromboembolism in ankle fractures to two cohorts of control patients that are commonly seen in the emergency department and often discharged home. So we chose to look at patients with a wrist fracture and those with a finger wound, and we used propensity score matching. And these are the results of our cohort. So over the 6-year study period, we had over 86,000 emergency department visits for an ankle fracture. And as you can see, we had just over 1,000 patients who developed VTE in the 90 days following that index emergency department visit. For a 90-day incidence of venous thromboembolism, we found that the incidence was 1.3%, which is higher than the quoted risk of venous thromboembolism in the general population, which is often quoted at 0.2 to 0.5%. In terms of our Cox proportional hazard model looking at risk factors associated with venous thromboembolism, in our adjusted model, we found that older age, hospital admission, non-ankle surgery, history of venous thromboembolism, and surgery for the fracture were all significantly associated with an increased risk of developing VTE in the next 90 days. In our matched cohort study, so we matched patients with ankle fractures to two cohorts, and we matched patients on over 30 variables to ensure that patients were similar at baseline. After matching patients in both cohorts, we had a good balance in covariates for both the cohorts, given that our standardized differences of the mean were all less than 0.1. And these are the results of our matched cohorts. And so on the left side of the screen, you have our ankle fracture versus finger wound cohort. And you can see that the hazard of venous thromboembolism was over 6 times that for ankle fracture patients compared to those with a finger wound. Similarly, in patients with an ankle fracture, they had over 5.5 times the hazard of developing venous thromboembolism compared to those with a wrist fracture. We wanted to ensure that patients with an ankle fracture weren't having a higher risk of venous thromboembolism due to an increased rate of surgery in this cohort. So we tried to account for surgery in the follow-up period, so between the index emergency department visit and the end of follow-up. And we tried to account for surgery in this follow-up period 2 ways. So one, we treated surgery in the follow-up period as a time-varying covariate. And secondly, we excluded these patients. And in both of these sensitivity analyses, we still found that patients with an ankle fracture had a much higher risk of venous thromboembolism compared to their control cohorts. So in summary, our study found that the incidence of venous thromboembolism was 1.3%, which is higher than the general population. And these patients with an ankle fracture had over 5 to 6 times the hazard of venous thromboembolism compared to control patients. Risk factors associated with venous thromboembolism is similar to what you would expect based on the literature, with age, surgery, hospitalizations, and a history of venous thromboembolism, all being associated with increased risk of venous thromboembolism. So in summary, we found that lower limb immobilization for an ankle fracture is associated with a higher risk of VTE. However, the overall incidence was still fairly low at 1.3%, although this was higher than the general population. So this goes to say that perhaps thromboprophylaxing all patients with ankle fractures is not the most effective way to provide thromboprophylaxis. However, future studies to identify which high-risk patients would benefit from thromboprophylaxis, where the benefits outweigh the risks, may be a beneficial way to offer thromboprophylaxis. There are, as I mentioned, risk stratification scores that are available, and once validated and cut points are identified, these types of rules might be able to help identify these high-risk patients where thromboprophylaxis would be helpful. There are several limitations to our study. So first of all, we need to consider the generalizability of our results. As I mentioned, this study was conducted in Ontario, Canada, where we have universal healthcare coverage, and so this might not be indicative of all other jurisdictions. And finally, we included all type of ankle fractures in this study, and some of these fractures may not have been immobilized. So I'm thinking more so along the lines of small avulsion fractures off the lateral malleolus that don't require immobilization. However, because we used ICD-10 codes, it's difficult to identify these small avulsion fractures. And finally, as I mentioned previously, we may have inadvertently included patients on anticoagulation if they weren't covered by a government plan. However, this would likely lead to a conservative bias in terms of the incidence and risk of venous thromboembolism. So in summary, we found that lower limb immobilization for an ankle fracture is associated with an increased risk of venous thromboembolism, and future studies should look at whether certain high-risk patients should be considered for thromboprophylaxis. Thank you very much for your time, and I welcome any questions.
Thank you, Dr. Grewal. I have a question for you. You mentioned in your limitations that because you used the ICD-10 codes for ankle fracture for your study, that you may actually have included in your cohort patients that maybe had like a small avulsion fracture. How many patients do you think might fit in that bucket when you think about it?
So I believe it probably was a small proportion. We did do a chart review at one site looking at the ICD-10 codes to see how many patients were actually immobilized in the emergency department. And in that one site study, we found that 94% of patients with the ICD-10 codes that we included were actually immobilized in the emergency department. And so, you know, that 6% that may not have been immobilized, that would likely lead to a more conservative bias of the risk of venous thromboembolism.
Right. There's another question from the audience. Based on the data from total hip and total knee patients, are anticoagulated only for short duration. And most of the studies of risk of bleeding typically are based on warfarin studies. what would the harm be for a short course of anticoagulation?
So bleeding risk would be the big issue, and also providing thromboprophylaxis from the emergency department. The question then becomes who's getting surgery, and would the anticoagulation need to be paused for surgery? And so I think there still needs to be some collaboration with our orthopedics colleagues in terms of, are these patients going to go home and undergo surgery in a couple of days, et cetera? And should they be started right from the get-go on thromboprophylaxis from the emergency department, or should this happen after surgery? So I think that needs to happen. The big risks, as I said, I think are mostly the bleeding risks, but for a short duration, probably smaller risk. However, given the low incidence of this, it might not be as cost effective in like the total hips and knees to provide everyone who has an ankle fracture with thromboprophylaxis.
I'm going to take one more question here, Don. What work still needs to be done before offering thromboprophylaxis to patients with ankle fractures?
So I think, as I was previously mentioning, I think we still need to identify who those high-risk patients are. Because this was a study using administrative data, a lot of the traditional risk factors that are associated with venous thromboembolism, we weren't able to elucidate. So things like obesity, smoking, family history of venous thromboembolism. And I think in coming up with a risk score, we need to consider those variables. So we need to still identify who these high-risk patients are, where we can identify these patients and offer them thromboprophylaxis. And then I think we also need to collaborate with our orthopedics colleagues to see whether it would be wise to start them in the emergency department on thromboprophylaxis or wait until follow-up.
Great. Well, thank you again, Dr. Grewal. Could we all please give another round of applause to our presenters today? Thanks again, everyone, for your time and attention. Please enjoy the rest of the conference.